Welcome to Focus on Health, a series of education programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome back Dr. Alyssa Gracely from Chesapeake Urology Associates.
Thank you for having me back.
You were on not too long ago talking about incontinence, which is a major women's health issue. I mean, certainly treatable and such. And today you wanted to talk about pelvic organ prolapse, which we kind of hear a lot about, and it can be a common problem, but it's certainly very treatable. And you're going to give us some information on exactly what it is, the symptoms, and how it can be treated.
Absolutely.
So first, let's talk about what it is, and are there different types, and it's called pelvic organ prolapse, so it's not just the uterus then?
It actually can be quite confusing for women because there's maybe 8 or 10 different terms that get thrown around. So the overarching term we use is pelvic organ prolapse, meaning the organs of the pelvis are descending. That can mean any number of things, and the symptoms are almost identical for all of them. So it's not something that the patient would know in and of themselves. There's sort of 3 walls to the vagina that this can occur to. And so if it's the front wall, we name it for the structure that's behind it, and that's the bladder. So it's bladder prolapse or a cystocele. If it's the back wall of the vagina, we name it for that structure behind it, which is the rectum or a rectocele. And if it's the top wall of the vagina that's dropping down and there's a uterus, we call it uterine prolapse. And if there's no uterus, it's vaginal vault prolapse. And any combination of those can occur.
So women that had a hysterectomy then, that would be what they would be experiencing.
Absolutely. But hysterectomy or not, they can have the same symptoms, and they don't need to know what it's called. They just know that we can help them.
Need to know when to call the doctor, correct? Or
Exactly.
the provider, sure. So why does that happen exactly? And of course, I imagine there's some risk factors involved.
Absolutely. So it involves loss or damage to the support of those pelvic organs or structures. So our pelvis has all these ligaments and tough connective tissue and muscles that support everything like a hammock. And in certain circumstances, that support can weaken or get damaged or tear. And when we lose that support, the organs and the walls of the vagina can sag down into the opening of the vagina, causing a bulge and that prolapse. Risk factors are anything that you can think of that might damage or stretch that support. So pregnancy and childbirth, and the more pregnancies and childbirths, the higher that risk. Certainly trauma or injury during delivery can contribute to that. Obesity, all that sort of extra weight in the belly can stretch those ligaments and the support as well. There are certainly some connective tissue disorders or that might predispose women to it. And surgeries in that region can also cause that.
And then I guess a lot of women just don't think about this sort of thing. They just start having a symptom or two. So what are the symptoms or things a person should notice, a woman should notice, and then say, maybe I should call the provider?
That's a really good question because there is a lot of confusion around what symptoms are related to prolapse and what might be related to other things from the organs themselves. So the number one symptom is a bulge. So feeling something coming out of the vagina. So that might be when you wipe, you feel a tennis ball, golf ball, sized something coming out of the vagina. It might be some fullness when you're sitting, feeling like you're sitting on something in the vagina. It could be noticing some laxity or fullness during intercourse, things just not feeling the way they used to. Or it could be that you might not have symptoms and your doctor might mention that you have some of that sort of loss of support and things moving into the opening of the vagina.
Is that something that can be picked up ahead of time with a pelvic exam, or you pretty much wait for the symptom to happen and then you would do the pelvic exam and diagnose it that way?
So a lot of women do come to me without any symptoms, stating that their physician told them that they have some prolapse. And it's super common. at least 50%, if not more, of women who've had children are walking around with some degree of prolapse. But only about 5% of women have symptoms that would prompt us to treat or do anything about it. So it's really worth noting that even though it's pretty common, up to 50% of women who've had babies, it's not dangerous or harmful. You're not going to lose your bladder on the side of the road or your uterus on the side of the road. It doesn't increase risk of cancer or anything like that. So even though someone might say to you, I notice you have a little prolapse, if they're not having symptoms, we really don't worry about it. We just watch things.
Okay. And so that's essentially how it's diagnosed, with just the exam, or would there be any other procedures or to confirm that a woman has prolapse?
Most often it is just with an exam. So someone who's trained to manage prolapse can do a very focused exam, have the patient sort of do some activities to try and reproduce that bulge. A lot of women, they don't really notice it all the time. It's more as the day progresses or if they do certain activities. So that exam might involve having them recreate some of the activities, taking a deep breath in and pushing to see that prolapse. Occasionally, women don't get that reproduction on exam, but they know it's there. They tell a really good story. And so then we can, it sounds silly and a little weird, have them take a picture at home. And so when they come back the next time, we can see what it is that they're experiencing. And often that might be an additional way to make a diagnosis if the exam doesn't give us all the answers.
Okay. So once it's diagnosed then, what are the treatments for this? And I guess start with the non-surgical approaches.
Yeah, absolutely. So the first thing is just to do a little education. Let the woman know that even though it's there, it's not harmful. And so if they're not bothered by it, it's totally appropriate to just watch things. And there are certain things you can do to help prevent things from getting worse, making sure you're not constipated and straining for bowel movements, work on an active, healthy lifestyle with weight loss if that's something that they're struggling with. And then pelvic floor physical therapy also can help prevent and might even improve some of the bulge symptoms.
I believe you mentioned that for female incontinence, and that was something I had never really heard of as far as physical therapy goes, but it sounds like it's very important.
It is, and once you get over the little mental hurdle of having someone trained work down in the pelvic floor areas, there's a wealth of things they can do to help with any pelvic condition, be it incontinence or prolapse.
Okay, and then what would be some surgical treatments or management of this?
Yeah, so if the conservative option isn't the right one, symptoms are too bothersome, physical therapy doesn't work, we can, before jumping to surgery, offer a pessary, which is this flexible ring or structure that goes up in the vagina to lift and support things. So it's not a cure, it's a management strategy. Using it won't make the prolapse go away if the pessary is removed, but for the time that the pessary is in place, it lifts and supports things and makes that bulge go away. It has to come out before intercourse, and we take it out and do an exam every few months to make sure that everything stays healthy. But it's a nice non-surgical option for people who just aren't quite ready or interested in surgery but are bothered by the bulge. And then surgery, of course, you mentioned, as a surgeon, that is my favorite thing to talk about, there's lots of options. And some of the options depend on the severity and the wall of the prolapse that's occurring. But it can be mostly outpatient surgery, so home the same day. There's procedures where we use stitches that dissolve in the patient's own tissue to lift and support things. Those are things called anterior or posterior repairs. The fancy word is colporrhaphy, but it's essentially lifting the front and back walls to give a little extra support. The next step up, if there's the uterus still in that's dropping down, are surgeries that remove the uterus, and that can be through the vagina or with small little keyhole laparoscopic incisions through the belly. And then the lifting or re-supporting of the tissue of the vagina once the uterus is removed can be done with stitches that dissolve to kind of connect it to some tough ligaments in the pelvis, or a piece of mesh that kind of wraps around the vagina like a sandwich to help support things. And last but not least, for women who aren't interested in being sexually active, there's a surgical option that essentially closes up the vagina and pushes everything back in there. It's a very quick, successful procedure that just uses the own tissue and dissolvable stitches, works incredibly well, but does close the vagina so that intercourse is not an option anymore.
About what percentage of patients that have, of people that have the prolapse go the surgical route? Is it a small percentage? Most of it can be addressed from non-surgical standpoint, or do you do a lot of these procedures?
So it all comes down to patient bother and quality of life and what works best for them. So with women who have mild prolapse and aren't bothered by it, we just watch and monitor with exams. For women that are bothered but not really ready for surgery, physical therapy or pessaries are a wonderful option. But if someone is just really bothered by it, active, does not want a sort of temporizing solution, but really more of a cure so they don't have to worry about it anymore, any of the surgical options that fit their lifestyle and their goals are a wonderful option.
Well, it sounds like many women choose to have children so they can be at risk for prolapse, you're saying. But are there any other preventive techniques you would recommend? Prevention?
Yeah, so that's a really wonderful question, and it's obviously what we strive for in medicine is to prevent these things from occurring. There's a good amount of research going into further risk factors and things that might be done early on to prevent. We don't have a lot of great solutions, but certainly maintaining an active, healthy weight, maintaining a healthy GI system where you're not straining a lot to poop and dealing with a lot of constipation can minimize the risks associated with being a woman and having a baby.
Sure, sure. I guess the Kegel exercises would be helpful, or?
So, yeah, Kegels are great for a lot of things, for stress incontinence and to some extent for prolapse. Anything that strengthens that pelvic support, the pelvic floor muscles, is a good option to help prevent prolapse or incontinence.
Well, that was a lot of information, and I thank you so much for coming on the program and talking about this topic, because I think women hear about it and they hear all those different terms, but they're not sure what they mean. So
it's a daunting topic, and it's one that doctors don't always get the opportunity to sit and talk for 20 or 30 minutes to really help patients understand what's going on. So I'm thrilled that you invited me to come and maybe give a little background to people who might be experiencing this.
Well, very good, and I thank you again, and we'll post some websites at the end of the program where women can get more information.
That would be wonderful. Thank you.
And thank you for joining us for this edition of Focus on Health here on PAC 14.